Hello and welcome to Chapter 22, Safe Mobility. In this module, we want you to explore age-related changes that affect mobility, increase the susceptibility to falls and to fractures. We will identify risk factors for osteoporosis and functional consequences that ensue with osteoporosis development. We will discuss long-term consequences of falls, fractures, and osteoporosis. Lastly, we will conduct a nursing assessment of musculoskeletal performance and identify nursing interventions directed towards safe mobility and the elimination of risks for falls and osteoporosis. Oops, sorry guys. Although most people think of bones, muscles, and joints when they think of mobility, in the older adult, safe mobility is also influenced by neurologic and sensory functioning to ensure that the older adult can interact safely within our environment. When we think of the normal function of bones, the normal function of bones is to provide the framework for the entire musculoskeletal system to support and protect our body organs and tissues. Bone also normally functions as calcium storage, as well as for the production of our blood cells within the bone marrow, which includes our stem cells, which differentiate into myeloid and lymphoid progenitor cells like our platelets, red blood cells, and white blood cells. So lots of different functions that the bone normally has. So as we're thinking about this, age-related changes specific to our bones include one, increased bone resorption, and this is related to increased serum parathyroid hormone. Another age-related change, number two, is diminished calcium absorption in the gut, so we have less being intaken orally. Three, impaired regulation of osteoblast activity, so that means more breakdown of the bone. Thus, the older we get, the higher the risk for osteopenia and osteoporosis. And the last age-related change is that we have fewer functional marrow cells, so we might see alterations in the production of our myeloid and lymph cells, such as the red blood cells, white blood cells, platelets, etc. Some of these age-related changes can be attributed to hormonal changes of aging, such as decreased estrogen in women and decreased testosterone in men. The muscles also undergo age-related changes, such as decreased size and number of muscle fibers, loss of motor neurons, replacement of muscle tissue by connective tissue and fat, and diminished protein synthesis. In fact, the medical term sarcopenia relates to loss of muscle mass, strength, and endurance. Age-related changes affecting joints and connective tissue are due to excess wear and tear, which starts actually in early adulthood, unfortunately. Unlike bones and muscles, which thrive with exercise, our tendons, ligaments, and joints become wore out over time. So physiologically, we see diminished viscosity of our synovial fluid in our joints, degeneration of collagen, and calcification in the joint capsules and connective tissue. Overall, this causes a loss of protection from forceful movement and degeneration of our underlying bones. Lastly, age-related changes in the nervous system include altered visual abilities, slower writing, as in like corrective reflexes, impaired proprioception, and diminished vibratory and positioning sensations in our lower extremities. All of these changes in our neurological system make the older adult more prone to walking slowly and responding more slowly to our environmental stimuli. We also see what we call body sway, which is a measure of the motion in the body while standing, and this can also increase our risk for falls. The next section we will look at is osteoarthritis and osteoporosis as treatable conditions that greatly increase the risk for falls and fractures. Osteopenia and osteoporosis are considered silent diseases because they're oftentimes unnoticed until a fracture occurs, especially if the fracture occurs when there is little to no trauma. This is what we call a fragility fracture. So it occurs when maybe a patient twists wrong and hits the edge of a hard surface, or they fall from standing. Normally, we wouldn't think that someone would get a hip or femoral neck fracture, But in someone with osteoporosis, this can fracture, causing major disability. As osteoporosis progresses, it can cause pain, loss of height, and increased risk for further fractures. Osteopenia is the precursor to osteoporosis, meaning that there is less bone density noted in osteopenia when we're looking at bone density scans, but it's not quite to the heightened level of osteoporosis. So when we look at a bone scan, we're looking at the bone density, so the amount of minerals that is found in a bone. And this is scored according to standard deviations, and it's called a T-score. A normal T-score is -1 to +1. In osteopenia, the score then is 1 to 2.5, a -1 to -2.5, and anything lower than that, so lower than -2.5, that's diagnosed as osteoporosis. Osteoporosis affects both men and women, and this is really a trending research that we're looking at is osteoporosis in men, because typically we really focus on women because they are at higher risk, but men do have osteoporosis and age-related changes in their bone. A recent 2016 statistic showed that 50% of women and 25% of men greater than 50 will have a fracture due to osteoporosis. Many of these risk factors cannot be changed, but numerous conditions can be addressed through health promotion interventions like tobacco cessation, increasing vitamin D and calcium in the diet. Normal daily intake should be approximately 1,200 milligrams of calcium with 2,000 international units of vitamin D. And another health promotion intervention would be to participate in weight-bearing exercises and regular physical activity. Especially in long-term care settings, nurses should take the lead in collaborating with dietitians, physical and occupational therapists, and our primary care docs in developing and implementing appropriate interventions. Pharmaceutical treatment of osteoporosis can improve bone density, reduce the rate of bone loss, and decrease the risk of those fragility fractures. But these medications all have some negative side effects that must be monitored and taught to the patient before use. Osteoporosis is the osteoarthritis that we're talking about now is the leading cause of disability in the United States. It causes pain, swelling, and limited movement in our joints, tendons, ligaments, and all those attached muscles that are affected. It develops gradually from the combination of genetics, obesity, and age-related changes. So nursing is tasked with promoting self-care, which focuses on programs and strategies to reduce pain and prevent disability. Some of these interventions include walkers and other assistive devices to help relieve stress on weight-bearing joints like our knees and help us improve balance. Another intervention is individuals with osteoarthritis need to participate in supervised low impact exercises. So the key here for osteoarthritis is low impact exercises. We want to do yoga, Tai Chi, water aerobics, and avoid those high impact activities like running that put a lot of pressure on the affected joints. Another intervention is maintaining an ideal weight, which might mean that we have to talk about weight loss in some patients with a higher BMI. Also teaching the patient how to relieve pain. We want to use moist heat and analgesics for pain, like Tylenol for pain, Tylenol arthritis. Heat is a good chronic pain choice. So if you're getting confused about arthritic pain and when to use hot and cold, we use cold for immediate injury to our musculoskeletal system, but for those long-term pain management, moist heat is going to be more comfortable. Lastly, collaborative care with OT and PT will improve muscle strength and promote safe and independent functioning. Risk factors that affect mobility and safety. So overall, lack of exercise is the most commonly occurring risk factor for all older adults in developing falls, fractures, or other musculoskeletal dysfunction. Nutritional deficits are important for preventing falls and fractures as well. Specifically, we want to look at calcium, vitamin D, and adequate protein intake, which will promote healthy musculoskeletal functioning. Is the following statement true or false? Exercise programs to increase strength and endurance in the older adult population may help delay the onset of age-related functional consequences of decreased strength and endurance. This is a true statement. Age-related changes in skeletal muscles, which are controlled by motor neurons, directly affect activities of daily living. The end result of these age-related changes is a decline in motor function and a loss of strength and endurance, even in healthy older adults. Exercise programs then to increase strength and endurance may help delay the onset of age-related consequences of disability and loss of function. Here's another question. Which statement is true? The answer to this is C. Osteoporosis can cause serious negative functional consequences even in the absence of additional risk factors like balance, environmental risks, things like that. Because osteoporosis is a gradual loss of bone mass that affects all adults to some degree, and is strongly associated with those fragility fractures. Osteoporosis is classified as primary when it is associated with age-related changes like the hormonal changes, and as secondary when it's caused by medications or other pathologic disturbances. Estrogen levels greatly impact the development of osteoporosis. In fact, most postmenopausal women will develop the greatest loss of bone density. More risk factors which affect mobility and safety. Numerous studies have been focused on identifying risks for falls in various settings, such as acute care, long-term care, and in homes. A general theme throughout the research is that falls are a result of a combination of risk factors, and the risk increases in proportion to the number of fall risk factors. So the more risk factors you have, the higher the probability that you will fall. Most falls occur in people who have multiple functional impairments, and these are things like sensory deficits of vision changes or gait changes, related to osteoarthritis and pain, or decreased muscle strength, which is just an age-related change, especially in our lower extremities. So they can occur in people who have these functional impairments and who also have multiple chronic medical conditions like depression, dementia. Those increase our risk for falls, as well as COPD and the ensuing fatigue that goes along with that. I encourage you to please look at box 22.2 to further give examples of this. Medications such as anticholinergics are strongly associated with increased risk for recurrent falls. And we want to remember that many of these anticholinergics are readily available to our patients, like Benadryl, bedtime Tylenol. It has diphenhydramine in it. In other ways, some medications can cause detrimental side effects after a fall has occurred, like our anticoagulants. At the hospital I work, we call like a mini trauma code anytime an older adult who's on Coumadin falls, because we want to make sure that they don't have hemorrhagic stroke or other internal bleeding. Environmental hazards which increase the risk for falls include clutter, poor lighting, and lack of handrails on stairs or grab bars in the bathroom. Physical restraints. A physical restraint is any device, method, or equipment that immobilizes or reduces the ability for a person to move his or her arms, legs, body, or head freely. This includes belts, hand mitts, soft wrist restraints, full side rails, etc. In the 1980s and earlier, physical restraints were used as a protective mechanism to reduce falls. However, there's been mounting evidence over the last couple decades that show physical restraints are not effective to prevent falls, and they're actually associated with a high risk of injury and fatality. The use of restraints is a huge liability and quality standard in healthcare institutions, and most organizations are moving towards limiting or eliminating the use of any restrictive devices. So I warn you to know your facility, know what kind of restraints are available, and you need to know how to document to keep that patient safe, as well as yourself and your license safe. Question, which statement related to risk factors for falls and the older adult is true? The answer to this question is B. The risk of falling increases in proportion to the number of risk factors, which we just talked about in the last slide. Falls are the result of a combination of risk factors rather than one isolated risk factor, and the risk increases in proportion to the number. Talking about functional consequences. So what are the consequences of our age-related changes? let's look at it. So through good nutrition and physical activity, most adults can compensate for the age-related changes. However, the consequences of osteoporosis and actually falling are quite serious. Looking at age-related changes, by the 8th decade, the strength of our muscles declines 30 to 50%, with more loss noted in our lower extremities than our upper extremities. This not only affects strength, but endurance and coordination. Joint function begins declining in early adulthood, which we kind of touched on in our osteoarthritis slide. And changes we may not see physically until old age, such as limited range of motion in our upper arms and decreased flexibility in the back, hips, and knees. Falls hit different in older individuals, right? Fragility fractures occur from something as benign as falling from a standing level. Serious and long-term consequences of fractures include disability, pain, poor quality of life, and an increased morbidity and mortality. In fact, hip fractures are associated with a significant functional decline, permanent admission to long-term care facilities, and high mortality rates during that first year. Lastly, the fear of falling, which is the most common reported fear among older adults, has been identified as a public health problem that is of equal importance to actually falling. This fear goes beyond prudent safety measures and is not a normal age-related change. The consequences of the fear of falling include increased dependency, activity restriction, social isolation, functional decline, and an actual increased risk for falling. The Centers for Medicare and Medicaid Services list falls as a never event. This means they're non-reimbursable when they occur in hospital settings or organizations that get CMS funding. Falls are the leading cause of fatal injury in older adults, according to the CDC in 2017. Falls in community settings are the most common cause of non-fatal trauma related to hospital admissions. Older adults are often very aware of the repercussions of falls, resulting in anxiety and a loss of confidence. Conversely, many older adults feel a loss of independence related to the strict fall prevention guidelines implemented in healthcare and long-term care settings. Thus, we want to talk about risk and benefit discussions, which are vital in planning and implementing safe fall prevention practices that allow the older adult to feel secure, but also to demonstrate autonomy in their own care. Now let's change to nursing assessment. The nursing assessment focuses on identifying risk factors for falls, fractures, and osteoporosis, with attention to those modifiable risk factors that could be alleviated through nursing interventions. Nurses use fall assessment tools to identify older adults who are at risk and would benefit from these preventive measures. On the screen here, you see one such fall assessment tool like the Heinrich 2 fall model. Another assessment tool is the timed up and go test. It has high reliability, uses minimal equipment, takes about 5 minutes to perform, and can be used to evaluate declines or improvements over time. Other assessment tools we can use as nurses is interviewing the patient about ADLs, about their use of assistive devices, as well as assessing the person's knowledge and attitude about assistive devices. Importantly, we really want to try to observe the client in his or her own environment, noting the person's awareness and attention to unsafe conditions. Because a patient saying, "I have no problem," versus watching them and going, "Whoa, you have a problem," is very different. Lastly, we want to ask specifically about a person's fear of falling. And one measurement tool we can use is the Falls Efficacy Scale, which is a well-known tool to measure that fear of falling. If abnormalities are noted on any tool or through any interview or observation, referral for further evaluation by a physical therapist is warranted. Now let's look at fall reduction strategies and planning for wellness. All older adults would benefit from health promotion interventions to prevent osteoporosis, falls, and fractures. Engaging in physical activity is a major intervention to promote. Regular exercise can improve muscle function, maintain bone strength, and balance. It's important to incorporate physical activity which is appropriate for the individual. For example, water aerobics is a low impact activity, and that would be a better fit for those with osteoarthritis. Other evidence-based interventions for exercise in older patients is Tai Chi and yoga. These are also low impact, but they promote balance, mobility, flexibility, and the mind-body connection. Formal fall prevention programs implemented in home care and healthcare settings assist with fall reduction. In healthcare settings, programs can address multiple risk factors, focusing on those who are at risk for falls and the consistent implementation of preventative measures. Some of the measures are identified in box 22.5 that are specific to the healthcare setting, such as non-slip footwear, having the call light within reach, utilizing bed and or chair alarms, and having close monitoring of the patient or sitter one-to-one sitting. In the community setting, fall prevention programs focus on education during each interaction with the primary care, and then encouraging community exercise programs, modifying medication regimens if able, and treating visual impairments or identifying visual acuity. Another aspect of fall prevention and education is the availability of help if needed. Some devices like necklaces or bracelets can alert the emergency response systems, which then summon help almost instantaneously. So our nursing interventions focus on restoring our functional ability, preventing further loss of function, and preventing falls and injury. Thus, our evaluation is based on a person's ability to achieve and maintain the highest possible level of independence and safe mobility. We can do this through the incorporation of preventative measures in daily life to ensure safety and prevent osteoporosis. Lastly, another evaluation outcome would be the client verbalizing expressed feelings of safety and improved quality of life. Thank you.